with that pediatric assessment project, I want you to choose something that really you want to learn about. Do you know a child that has, or you saw a child in clinicals that had, or your sister, your child, you, somebody had something and you wanted to learn more about it? If you make it something interesting, it's going to be not just getting the work done type project, okay? It is 3 sections. I've already had somebody send me in one section already. It was the APA 250 word section, and I actually put it into APA form, sent it back so they could see it. So, I mean, I will help you get your best grades possible, but you can't send it on the last weekend and have me help you. This needs to start now. So just, it's not a problem. Upload it to the modules, all right? Those modules have multiple uploads so that you will be able to resubmit. So don't be afraid, oh, if I do it now, it's not going to go up when I need it. No, it still will. The second section is that assessment form. It's quite lengthy. Remember, on that assessment form, it's the end where it talks theorists and it talks about nursing diagnoses. I look at quite closely. And remember, if you're talking about things that are respiratory components, I'm going to really look at that respiratory assessment. Don't give me a normal clear lungs when they, if they have that condition, they could be retracting and they could be nasal flaring and grunting and bronchi, wheezing. I want to see that. Tachypnic, show me that in your assessment, okay? So, and if I don't see it, I'll send it back. There's something to do with dietary restraints. I want to see something in there about it. So just to let me know that you understand that. And the third part is simple. Most students do a 5, 6 slide PowerPoint. I don't need 28 slides. No, very short, concise, and brief. Teach me something. Talking about ADHD, what would you do to help this child organize themselves? Is it that structure at home? Do you have to, would you recommend therapy? Our medications? Anything, 5 slides, just teach me something about it. So there's 3 sections. As you get them done, send them in because it is 6% of your grade. That is more than your NCLEX, and that equals all of the CJ Sims in a grade. And that is a subjective grade, and it can really hamper your final grade if you don't get a good grade on it. So I believe that my job is not to say, no, wrong, wrong, wrong. I'm going to show you how. Because many of you are going to go on for your BSN and MSNs. Maybe not right away, but you probably will. And APA formatting, I had no clue what that meant when I went back for my BSN. So I'm just trying to show you an introduction to teach you, to show you, so that as you go forward, it will be easier, okay? So that's what I will do for you, but just send it in early. So next week already, we're starting reviews again. I have just gone over one exam. I've just gone over all the concepts in them, and I'm making and going over the review, making sure those key concepts are there for you. So I always ensure that you've heard of something. I don't think there was anything in exam one you could say you never heard of. It was there, whether in a PowerPoint or in that review itself or in the Kahoots. And the Kahoots, it's a lot in the Kahoots. So just that's what you need to be reviewing. You do have a discussion question due, and you do have one CJ Sims due. We had some back and forth with some of the CJ Sims, but make sure it has 4 components. Has your name in the right upper quadrant, has the name of the Sims you did, the date that it was done, and your grade, okay? And I gave everybody grace for the first Sims, making sure that you had the chance to turn me in what I needed. Some people know how to take it and click it right off of the site and give me a cute little picture. Some took pictures of your computer screens. It doesn't matter as long as I get all of those pieces there, okay? I have to see it. So, any questions about anything so far? All right, what we're going to do is week 5. Week 5 is probably the basis for nursing in adults and in children. It is cardiac and respiratory. Cardiac and respiratory, if you don't have a heart and lung, they don't beat, you don't breathe, we know that there's going to be problems. So let's go and let's relate it to children. Now, I'm not going to go over every slide in this PowerPoint. I'm going to go over those key concepts that you need to know, and that this PowerPoint is here for you to go back and look more. And of course, if you're not understanding, there's always the book. So, children, we have respiratory infections. You have the upper, which is it's the ears is a lot, right? The sinuses dripping. Their children are always with, the mucus, nasal mucus, and they're always with a mucus in their throat. That's all upper. And then, of course, the lower, we would call that maybe a bronchitis. That's the bronchioles inflamed, or a pneumonia. Now, most things we get in the lungs are viral. Now, one of the biggest things that we look at with children, especially young ones, is something called respiratory syncytial virus, or RSV. RSV, and you can see the difference in symptoms from infant to adults. Me and you, it's a common cold. You get nasal mucus, low-grade fever, you sneeze, you don't feel too good. An infant has a struggle just to suck, swallow, and breathe, right? That is their biggest thing in life. Then take the infant who likes to breathe through their nose and put mucus in it, they can't breathe, right? So it becomes now a problem and could, increase respiratory effort. So infants are the ones that we really treat the most. Sometimes it can be due to other things, but let's just consider all viruses right now. So, infants that are born has all of mommy's stuff, all of the antibodies, all of their hemoglobin, their iron, and they come out, with a little bit of that immune system that you would want. But it starts to be going away, just like all the cells start to go away. And the red blood cells, they're going to have, by 6 months, they could go from a 14 hemoglobin down to a 10 or a 9, which is normal. Then the body will make its own. So, how do we increase an infant's immune system? Well, we give immunizations, right? 2 months, 4 months, 6 months, we give a lot of them. Also, as a child starts getting colds, that's how the body builds up these antibodies. So by the time they become toddlers, and remember, I call toddlers the children who go to daycare, and all they do is play all day long. And they take toys from one mouth to the next one. So I say they swap spit all day long. So they swap their germs around and around. Is this good? Well, parents don't want their kids sick, but they're getting those immunities, those antibodies, because they've gotten sick. So by the time they get into school, they're not going to be out a lot. As they get older, it's more of those bacterial infections that they really increase, because you don't really get antibodies against those bacterial. You need to treat them with antibiotics. So as we get older, we get all of our immunizations and we get these infections, our immunity increases. Now, otitis is always a tested subject. Otitis media is an infection in the middle ear. Why do kids get these all the time? Well, they have these short, straight tubes that are open. And what did I tell you about kids in their upper airway? They're full of mucus. Where is the path of least resistance? Up the eustachian tubes. So it festers in those eustachian tubes and it creates a lot of problems. Now, usually the kid gets an ear infection. We'll put them on an antibiotic. And of course, tell them to blow their nose gently, type thing. And many kids have multiple every year. If it becomes more than 3 or 4 a year, they might go ahead and put tubes in. You know, in August, I actually had a tube put in my right ear. I suffer with whatever, and I had it done in the doctor's office. I understand why children are knocked out because it's not a pleasant feeling to hear them cutting what's in there, putting the tube in, and suctioning out the liquid that's there. I mean, it takes a second to get done, but it's not nice. So, as I said, they're short, open. That's why they move up there. Now, what does a kid look like? Now, any kid who's getting sick, number one, they're going to stop eating. That's a kid. Adults, we keep eating because we don't care. We're hungry, we're going to eat, but kids don't. And they're going to become quiet. If they have pain, they're going to tell you, and they're going to tell you what ear hurts very easily. They're going to have a fever of some sort, low or high, doesn't matter. And they might get the vomiting, diarrhea. It might be because of mucus, a sore throat, a cough, and then you might hear a lot of noisy respiratory sounds. It might be upper airway that you hear in the lower airway, but it's sounds that you're going to hear. So what is our goal? Well, if a kid's not breathing well, we want to breathe them better. I mean, easy. We want them to breathe easy without any effort. We want them to be able to rest. I mean, kids need to rest. If they don't, they're cranky, right? Also, we don't want to spread that infection around. We teach kids from an early age now how to wash their hands, and how to cover their, mouth when they're coughing. It's all that, the COVID, right? That really put it into light. Now, a kid who has a fever is not going to move, not going to eat, not going to drink. What do we want to do for a fever? We want to give extra fluids, right? If you get that fever down, you take a kid from sitting in the corner, quiet, not wanting to do anything, and within 30 minutes, they're up and around and running, drinking, and eating. So keep that fever down. Then you will get the hydration and nutrition in there. Now, we've all heard about the kissing disease, right? Infectious mononucleosis. Well, it is a virus. It is a herpes-like Epstein-Barr virus. It presents with a fever, sore throat, and like overall body aches and pains, and maybe lymph nodes get swollen. But you can also have a swollen liver or spleen. Many times, this is very difficult to diagnose. A lot of children come in with sore throat. We'll do a strep throat. We'll do a culture, negative, negative, negative. So they'll say it's just a viral pharyngitis. They keep sick. They go back to the doctor. And when they go back to the doctor, they'll say, okay, let's put you on an antibiotic. A couple days later, they're still sick. And that's usually when they'll go to urgent care or to an ER. We hear the symptoms and we're going to draw labs. What we draw is a CBC because we're looking at white blood cells, right? White blood cells are normal. It's a virus. We're going to do a mono spot test and it's going to be positive. Now, what is the big thing about mono? I told you there's swollen lymph nodes. There's a swollen liver or spleen. It gets big. And if we tend to hit it hard, that spleen can rupture like a big balloon. So, one thing about mono, no contact sports. I'm going to tell you a quick story about a 9-year-old who came in to the ER one Saturday morning with his father and had all the symptoms I just described. He ended up monopositive. We told him, please, no contact sports until you go back to your pediatrician, until you're cleared. Usually 3 weeks, we say no contact sports. 1 week later, I'm the primary trauma nurse on duty, and I get this call. Kid was on a 3-wheeler out in the Everglades, fell on his abdomen, and he came in dead on arrival. His spleen had ruptured. Now, the father was taught well by the physician. I taught them, please make sure, protect it. You have brothers, sisters, protect that belly. So, infectious mononucleosis, the kissing disease, please protect their bellies. Now, bronchitis. There is bronchitis, tracheal bronchitis, and there's epiglottitis. They're all an inflammation of the airways. Now, bronchitis is usually, that's when you get this dry, hacking cough, usually at night, and it keeps you awake all night long. There's nothing that comes up. You just cough, you cough, you cough. So what they do is they give you a cough suppressant. If you have a fever, usually not, but if you do, you might take an antipyretic. But it's that codeine medicine in the cough medicine that will relax and stop that cough from going on. So bronchitis, and usually that's your Z-Pack that we usually hand out on those kids. Now, croup, laryngeotracheal bronchitis, is usually again by a virus. And this is when those kids are barking. You can hear them bark, bark, bark. Now, upper airway is getting swollen. Airway is shutting down. It's inspiratory. You can't breathe in. So you can get air in, but it's very difficult to pull it in, but you can breathe out just fine. Now, that's why that swelling causes that cough, and it is a barking cough. Now, usually, as I said, it is a virus. And usually, you've already had a cold and it progresses, the swelling in the upper airway continues, and then you start with all the signs and symptoms of respiratory distress in children, inspiratory stridor, substernal retractions, the coughing, barking. And then if we let this go continually and it's swelling more and more and more, it's going to lead to respiratory failure and respiratory arrest. Now, this laryngotracheal bronchitis, if it's not treated, and all we do is need to reduce that swelling. So it's a steroid, it's a virus. We need a steroid to stop it swelling. If we don't get it to them, that whole epiglottis, which is that leaf-like structure that covers the trachea when we swallow food, okay, gets so swollen you can't breathe in, okay? There is maybe a little piece of space where you move a little bit, you can find it where you can breathe. What are the signs and symptoms of it? Well, because you're not getting enough air, you're starting to get agitated. That's the hypoxemia that's going on. You can't swallow because all of that swelling there, you're drooling. You're not going to be able to cough. These children will have these like frog-like muffled sort of talking. They can't because it's so swollen back there. Now, what do we need to be concerned as nurses? Well, we want to make sure that initially, of course, it's emergency. These children are number one. Usually when they come into the ER, number one, back to a room, we're going to do initial treatment, getting the doctor in there right away. But make sure you get someone to get you an intubation tray and a tracheostomy tray at bedside. Many of these kids, even with racemic epi and an aerosol, getting an IV in, giving them steroids, it's still swollen. So airway, 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 they can't breathe. So your thing is to keep them breathing as well as they can. Also, to make sure you have equipment there in case you have to do something emergent. So once we get this airway open, the swelling decreased, we want to keep that airway open. Sometimes the hydration is through a mist of oxygen through a mask, and that moisture goes down to the throat. If this was an epiglottitis, you're not going to give this kid oral This kid will get intravenous fluids, keep the fluids going. You'll always want to maintain hydration. If it's a group, we might just give fluids to these kids. And as I said, nebulized treatments, we give that racemic epi. And that's epinephrine that goes directly through a mist right to where it needs to go. So I mentioned RSV, right? And this is something that can be dangerous for those young kids. I would say they say 1 year and less. I say 6 months and less. Those little kids. So, what if you're premature? What if you already have a lung condition? What if you have a cardiac condition? What if you have cystic fibrosis? I mean, what if you have something that you already are struggling to just suck, swallow, and breathe? Well, you don't want to get RSV. So, what they do is there is an immunization from winter to early spring once a month, and it's called Synagis or palivizumab. It's a biologic. And what that does, it prevents this child from getting RSV. And that's what we want to do, especially if they're already compromised. Now, what is the most common of things that we do for children? We tonsillectomy, adenoidectomy, and tubes. I mean, those are the big three that we do. So how do we take care of these kids when they're done with surgery? Well, postoperatively, you've got the sides of the throat where they've cut out the tonsils and they've cauterized the area. So they're big scabs that are back there. So no irritating seasoned foods, like no orange juice, no really spicy foods, because it will burn. No gargling, minimal toothbrushing, brushing your teeth, minimal. You don't want to be aggressive. Nothing, 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 nothing in the mouth. No looking down there to see, oh, are you bleeding down there? No, because you can increase it. What we do is we'll give them just acetaminophen, ice collar. Now, young kids don't want that ice collar. They'll throw it off. But the older kids, you can keep them resting, right? And one of the things we don't realize in older kids, they get ear pain, and actually chewing gum helps. So medicate them for pain, nothing in the mouth, ice collar if they can do that, and then chewing that gum can really help. Now, tonsillectomies, usually after 7 days are okay. I mean, I've actually seen one at 7 days go to the doctor, was just looked at, and on the way home, vomited clots of blood and was rushed to the ER. Of course, I'm in the triage area, and this little girl is just vomiting these big clots of blood. She went hemovolemic very quickly. I literally picked her up, ran her into the trauma room, called for a doctor, got someone to help, got an IV. A 7-year-old little girl, I had to give a liter of normal saline, 1,000 mLs. It was a lot of fluid she went behind. Her heart rate was 160. Her blood pressure was 70/30. This is a 7-year-old child. So it can be dangerous. So again, having these kids be quiet for the first at least 5 to 7 days, very important, and nothing in there. And again, if we're smelling some bad smells, it could be infected. Now, pneumonias. Pneumonias can be due to viral, bacterial, could be inhaled, right? So, what do we do? If it's a bacterial pneumonia, that means a bacteria caused it. Augmentin is usually your antibiotic we start them on right there. If it's a viral pneumonia, we do supportive care. We give acetaminophen, ibuprofen, and fluids and rest. It's just supportive. An antibiotic doesn't help virals, okay? So if it's viral, we're just going to support them. Now, they do have that pneumococcal vaccine now, and we give them pretty young. And mycoplasma, again, that's usually like your 5-year-olds. And that is one that we're going to have to put on several antibiotics to take care of it. And it's usually one of those start them on augmentin. It doesn't work. Let's try something else. Now, years ago, it used to be great to put baby powder on the baby's butts, right? Johnson baby powder smells so good. But they have found that that little talcum in the air, they can inhale it, and it can be very dangerous. That's one way of aspiration. The other one is that child who has a difficulty with eating and is always spitting up, right? If a child is vomiting, especially infants, they can aspirate it and get aspiration pneumonia. So, how would we treat the aspiration from powder? Well, we're not going to give any powder, put any on that child. Smells good, but no, don't do it. The other thing is if we're feeding them, or make sure that they're burping well, making sure they're not overfed, and making sure they're sitting up after they're done. And that will help. Another thing kids like is they put everything in their mouth. Last semester I was teaching this area, and my 9-year-old grandson had a quarter in his mouth and went to kiss his mother or something and swallowed this quarter, and it got stuck in the throat. He ended up having to have surgery with a bronchoscopy to get it pulled out. And it does happen, especially young kids. And I wish I could tell you it was the dimes or the pennies because they're smaller. It's always the quarter. It's the quarter and it's large, right where that picture shows it. I can't tell you how many quarters I've seen. Now, how do we usually, or how can we get rid of this stuff? Well, what they did was take a Foley catheter with a balloon, put it down the mouth below where that coin would be, blow the balloon up, and this child would sit on the surgeon's lap and pull it forward. And that child would vomit. And because the balloon was inflated, the quarter would come up with it. I would always tell the kid, all right, it's going to come out of your mouth. If I get on the floor and get it first, it's mine. So now the kid's not worried about what's going on. He's worried about, I want the quarter that's going to be coming out. Is this a distraction method that I did? And let me tell you, it worked really well. They can swallow anything. Aspiration. I've seen a French fry get lodged in an airway and created a lot of problems. We couldn't get it out. This kid ended up on a machine called ECMO, which breathes for you. It's like a heart lung machine, but it only works as a lung. And the kid died after 3 days from a French fry. So making sure things are cut up smaller, etc., was the important things here. Foreign body aspirations, number one, make sure they're breathing. Once they did that extraction of that quarter, we monitor them for a couple hours, making sure that they're still breathing. Now, pertussis is something that should be gone. We have immunizations for it, but not every child is immunized. So a kid comes in who's coughing. Do we know if it's an upper respiratory or if it's pertussis, right? And pertussis is highly, highly contagious. Yes, we have the vaccines. It is really a hard thing to cure, and especially because it does spread so quickly and so contagious. These kids are put into these reverse airflow rooms so that the air doesn't go to the population, and they're put actually on Zithromax, and that is the treatment for it. And then, of course, respiratory care. And of course, saying, hey, you really should vaccinate your child. Smoke inhalation, always know that anything with a fire, with smoke, We always have to worry about airway, making sure that their oxygen saturations are good. And remember, sometimes it's not right away you see it, that swelling can occur later on. We know tobacco smoke, one of the big things that tobacco smoke can cause is ear infections. So nobody should be smoking in the house around children. Now, cystic fibrosis, many times we know because mom or dad, somebody has it. So we know that gene is there. Sometimes we don't. What would we and how would we figure this out? Well, cystic fibrosis, one of the presentations is at birth, they have what we call a meconium ileus. That means the meconium, the first stool, doesn't come out. It sits there. They're constipated. I mean, newborn children are usually stooling on the way out. If they have not passed the stool in 36 hours, they'll be testing for cystic fibrosis. They'll be checking for thyroid disease. They'll be checking for Hirschsprung's. We're going to go into that later on. Or we'll also be checking for any sort of intestinal obstruction, whether it be physical or something's going on. But cystic fibrosis is constipation at birth. Now, cystic fibrosis is mucus that collects in the lungs and it collects in the small intestines and it clogs up that small bile duct and that pancreas area. And what do we see? Well, if we figure out, let's say you have a newborn, no stool, figure out cystic fibrosis. If that mother licked that infant's skin, it would taste very salty. They lose salt like crazy. So you'll never restrict salt on these children. They need it. They lose it like crazy because it affects the lung. The lungs are like thick petri dishes full of mucus. So this is the most aggressive chest physiotherapy that you will do. These children will be getting aerosols, that bronchodilator, albuterol, loosen it up, and then they'll do chest CPT when they're done and then they can eat. We never do the chest CPT or these albuterol aerosols before they eat because they'll just vomit. So we do it before they eat and then they can eat and then their airway is clear also. Because it's so much mucus, they get a lot of infections. You have these children on aerosols with antibiotics, oral antibiotics. Now, and you're going to hear all those respiratory sounds, wheezing, shortness of breath, because this mucus is occupying space in those lungs. Now, what happens with that small intestines and all of this digestion? Well, they don't digest fat. They don't digest food. So you are going to have these stools that are greasy. It's the fat, right? And it's going to stink. It's very, very distinctive smell. It's foul. And it's also going to be bulky because they're not absorbing all their food and it's going out in their intestinal tract as stool. They're not going to be gaining weight the way that they should. So, cystic fibrosis is twofold, lungs and small intestines. Now, after we diagnose cystic fibrosis, which is a simple, what we call a sweat test, and all it does, it measures the salt on your skin. Like I said, if you licked it, you're going to taste it. Now, treatment, we're going to, treat infections, of course. We're going to keep that airway open with those bronchodilators and then all that chest physical therapy. And then they're going to be put on pancreatase medicine, which is because they have pancreatic insufficiency, which means that these children are not breaking down food so they can use it. The pancreas is affected. So, what does the pancreas do? It secretes insulin, right? So these children will be watching their blood glucoses. They can develop diabetes from this. Not initially, but eventually they could. Now, the medicines that we use, if they're enteric coated beads, we'll never crush them. They have to take them whole. You can put it in a little bit of food and they can eat it, the younger kids. If there's powder, you can sprinkle it on some food and they can eat it. One thing about powder, because it's very damaging to the enamel on the teeth, make sure they rinse their mouth when they're done. And the one thing I think that's forgotten, children grow, they gain weight, they need bigger doses. So make sure that those dosages are adjusted. So that's very important. Cystic fibrosis, the pancreatic medicine, know that the pancreas can fail, monitoring blood sugars, and that physiotherapy on the chest. So it's exactly what I told you there about the management of the respiratory, keeping those lungs open. Usually it's at least twice a day. And then those GI problems. Now, if I'm telling you fat is not absorbed, you're going to have high protein, high calorie, low fat, right? Because the fat's just going to come out. As I said, it could end up with problems with the pancreas. So monitor those glucose levels. And we're going to be really monitoring growth on these children and their weight, making sure they gain weight because they're not absorbing food at all. Now, cystic fibrosis and women and becoming pregnant, they usually can. Usually there's not a problem. When there's a problem, it's usually the men. Now, I've seen men, young men, want to, get married, want to have children. What they do is a bilateral lung transplant. And 1 year later, they're able to father a child. Has something to do with the mucus and the clogging, and with the cystic fibrosis in the lungs, it clogs the vas deferens, and then the sperm can't get to the mother. Okay? So, men after 1 year bilateral transplant can have them. Sleep apnea, I mean, how many snore at night, right? I mean, you have young kids who do also. And the one thing about sleep apnea is if it becomes more of a problem, get to the doctor. You might need to have, your tonsils or your adenoids out. That could help. It also can cause these children to wet their beds at night, secondary enuresis. And these kids can be tired during the day. So it's something that needs to be addressed. As I said, usually it's the surgery that helps correct it. Usually it's more the overweight children that it happens with. And then, of course, they have those machines today. Very easy, put them on, and they sleep with them at night. ARDS is when the lungs are really traumatically injured for some reason. It could be due to an accident. It could be due to overwhelming infection, sepsis. It could be due to a drug overdose. That's more your adolescence and near drowning. Probably the sickest kid in the unit will be ARDS. Prognosis is really poor because the lungs aren't oxygenating. They're in the unit sometimes. And if you look at that little blood stuff going on there, that's an ECMO machine. It pulls blood out, it oxygenates it in an artificial lung, and it puts it back in. Has nothing to do with cardiac output. It's all about oxygenation. And sometimes they come through it. You will see questions like you did see on the last exam, CPR, something to always look at. One of the things we forget is CPR when you are the nurse and it's the parent watching their child go through a cardiac arrest. Make sure somebody's with them. We used to have them thrown out of the room. Get out of here. Go, we don't do that anymore. because if they die, we want those parents to be there holding their hands, knowing that everything was done. Now, asthma, one of the most common childhood things, right? What happens? Well, the bronchioles are hyperactive, hyperresponsive. Could be due to an allergy, right? We diagnose them, pulmonary function tests, making sure they're breathing good, and of course, doing those skin allergy testings. What to avoid? And one thing that we try to recommend is keeping these kids with normal activities. Now, if you have a kid with asthma who has a grass allergy, you wouldn't have them out there playing baseball or soccer, would you? This is a great time to put them in the swimming pool. Swimming pools, they hold their breath, go underneath. It's great long exercises. So, things that we can say. Now, have you ever seen a spacer before? Those bottom left three pictures are from small, medium, and large. You put them on. We even have kids holding them and pushing them for themselves. And it makes sure they get the medicines, like that little boy there, right? So, long-term treatment. Well, we're going to be giving them what we call that preventative type of aerosol, morning and night. In children, we give something called Pulmicort. It could be Atrovent in the older people, and it's morning and night. It prevents bronchospasm. Well, what if they're having a bronchospasm? That's when you give those quick relief, the rescue, the albuterol, the Ventrin, the Ventolin, right? That opens up the lungs right away. And if we get to the hospital, it'd be the steroids that we give also. And then, of course, we're going to give that the medication like the antihistamine, like a Claritin at night. I'll remember it as we keep going. Status asthmaticus. Now, I had the unfortunate opportunity to see my husband do it for 12 days in a row. And it really brought me back to life and learned a lot. In a time where you cannot catch your breath, it's the most scary time that any child or an adult like my husband could have. Happened like 5 years ago. Well, the thing with status is it doesn't stop, that you keep wheezing. And at this point, what is our goal? Well, we're going to be giving the albuterol, we're going to be giving steroids, and we keep going. We're going to be giving, that aminophylline and maybe some sort of ventilation if at all possible. I was very blessed. My husband never had to go on a ventilator only because I was with him and I didn't leave his bedside and I could calm him down. COVID-19, right? That's brand new, something we looked at. Know that COVID-19 can really affect the lungs, and we know that the big thing is immunizations. Now, cardiovascular can be overwhelming. Know that respiratory, what does a kid look like with respiratory? When are they having problems? That nasal flaring, that grunting, that retraction, that restlessness. I mean, that's pretty quite universal, except for nasal flaring and grunting. Those are your infants in all age of patients. Cardiac dysfunction are we're going to be talking about mostly those congenital things. Now, there's a lot of different diagnoses here. I'm going to hit you with those things that you need to understand to get you through exams, through your HESI, and through your NCLEX. I worked 10 years in a cardiac ICU for children. And I learned a lot about them. If anybody wants to go more in depth, I will with you, but it's something that it took me a long time to learn. We know that there's congenital, you're born with it. And then we know it acquired. And acquired, it's usually that infection, usually viral and cardiomyopathies can happen. Now, this picture is in your book. And I'm going to describe one condition with this picture, and hopefully with it, you can see blood flowing. Now, if you don't know how blood flows through the body, through the heart is something you need to look at. Um, I'm going to start. It starts in the right atrium through the vena cava, goes through the tricuspid valve into the right ventricle, goes up through the pulmonic valve into the lungs, goes back through the pulmonary veins into the left atrium, through the mitral valve into the left ventricle. That left ventricle pumps it out through the aortic valve, through the aorta, over the arch, and down through the body, and it comes back to the right side. Okay? So there's right-sided failure and left-sided failure. Well, let's talk about a left-sided failure issue that you see a lot of questions regarding it. What would happen if that red line coming off the left side got a kink? Right after those little three things up top, where are your subclavians? Everything goes to the upper body, the carotid arteries, internal, external, right? Right after that, it's kinked. What happens to that blood? It can't go down. Well, what would you see? What assessment? If blood can't go down, it's not going to the organs, it's not going to the feet. You're going to see decreased or no pulses in the feet, which means no dorsalis pedis, no posterior tibial pulses. Your feet might even feel cold, all right? But blood doesn't go down. Blood pressures are going to be low too, right? There's no blood. So that's lower extremity. Upper extremity, what are you going to see? Well, if the blood can't go down, it has to go somewhere. So it's going to go up into the head. Older kids, you might see headaches and nosebleeds. Infants, it's going to go back down into the left ventricle, up into the left atrium, and goes back into the lungs where it fills up. And you're going to see a kid in congestive heart failure, tachypnic, tachycardic, huffing and puffing, because blood can't go down, it goes somewhere. That's called a coarctation of the aorta. You will see things on this. This is a big concept that you need to know. So a kink in the aorta, blood can't go down, lower blood pressures in the lower extremity because all the blood's on the top, higher blood pressures in the upper extremities, and because blood's got to go back somewhere, it fills up the lungs, goes back through the left side, okay? That's coarctation of the aorta. Many times you'll have children that are older, and I can't tell you how many 2 and 3-month-old kids come in, coarctation of the aorta, and all of these things on this history and physical were the signs and symptoms. Well, if your lungs are full of fluid, you're not getting oxygen, are you going to breathe well enough to be able to eat? No, you're going to tire out. So you're going to have poor feeding. And the heart's trying really hard to get that oxygen around. So they're tachycardic, right? They're tachypnic because they're trying to breathe, but there's no room for oxygen in there. So they're tachypnic, tachycardic. They're not getting their nutrition, so they're not having any weight gain. They might even be losing weight. Activity, they can barely eat at this point. They're so exhausted. They're not getting nutrition, developmental delays, right? You may or may not have a history at all, may or may not. But one of the nursing diagnoses that you would see on an infant who came in, coarctation of the aorta, with all of these symptoms would be inadequate oxygen perfusion leading to activity intolerance resulted in diminished energy to breastfeed. And they're going to be skinny. They're going to be underweight. And you will see those developmental delays and maybe not lifting their heads up when they should because you don't feed the brain, you don't feed the fuel, they're not going to work the way that they should. So what do we look at when we look at kids, cardiac? Well, what is their weight? Their nutrition status is always by weight. What's their color? I mean, this kid on the right, you can see that they're purple. They don't look too good. You're going to see sometimes retractions. Sometimes put your hand on a chest of an infant with a cardiac problem and you can feel murmurs, especially when that murmur is between that two lower chambers, the ventricles. You'll feel like a bee, 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 almost like that. That's what you feel with your hand. Again, those unusual pulsations, the way that they're breathing, you're going to say something's not right here. I mean, flipping of fingers, that's later on. We're going to be looking at these kids, listening to the kids, feeling for those pedal pulses. You know, before I really understood cardiac, I found one coarctation in my career. And I'm like, there's no pulses here. And we told the physician, they did an echo right away. And I was right. I was just so happy I caught a kid, you know, and we prevented that left ventricle from getting stretched and all of that fluid to the lungs before they went home because kids go home really quickly today, don't they? We're, you know, number one, you always do an EKG. That's just number one in any cardiac, and we do an echo. Now, if you do an echocardiogram and something doesn't look right, be prepared that kid's going for a cardiac catheterization. Cardiac catheterization is looking for what's going on there. If they're older and has problems, it might be interventional, but I'm not going to go even that far into it. Now, you might get a kid back from a cardiac catheterization. Cardiac catheterization puts catheters into the right femoral artery and the right femoral vein. And these are big catheters. So, what is your job when they come back from this procedure? First of all, number one, I will always check the dressing on their groin. They do put a pressure dressing. Older kids might have a sandbag. Young infants, no. If they're bleeding, they bleed out so quick. These femoral artery and vein are big vessels. They'll bleed their blood's, you know, volume out quickly. What if they are bleeding? What do you do first priority? You want to stop the bleeding, right? You put your fingers right above, like if you have your leg and you have your heart up here, you put your fingers, two of them, right above and push down. And then you call for help and just hold it. That's all you do. And it's okay because that's actually the way they stop bleeding post cath. If you go into cardiac cath nursing, I've done many post procedure adults and children of cardiac cath in right post procedure. You just hold it, and once it stops, then you can let it go and put dressings on there. Biggest risk is that hemorrhage. Okay, put your fingers now. You will do after that, do your vital signs. You're going to check pulses, and I'm guaranteed that right leg is going to be slightly less, not as strong because they intruded it with these big vessels and there could be a little swelling. So tell the next nurse exactly the way you feel. They need to get their fluids, so IVs or PO, whatever. And we always monitor blood glucose levels, making sure that they didn't give any glucose rich fluids in cardiac cath too high, or they've been NPO too long and now their sugars are low. So we'll be checking that. Now, one of the biggest denominators for congenital heart defects are your Down's children. Down's children are the ones that we see a lot of ventricular septal defects. Well, what is a septal? Septal is that division between the right and the left side. A ventricle, you have the right and the left ventricle. It's that partition, there's a hole. So blood is swooshing back and forth. That just means blood is still going back to the right side and going to the lungs because nothing's holding it. Like the atrial, blood's going back to the right side and going back to the lungs. So it's an increase in pulmonary blood flow. So congenital heart defects, Down's children is a big one. It's one thing you're always going to look at. Now, there's a bunch of different defects here. So what I want you to listen to is those things that are important. Well, coarctation of the aorta, I've already mentioned it. Remember, it's a kink in the hose. Too much flow is going back and filling up the lungs, and nothing's going to the feet. No pulses. You're going to see the most tested area always is tetralogy of flow. Anybody ever hear of a TET spell? TET spell is when the pulmonary artery, for whatever reason, a tissue flaps over, it spasms close, and it shuts. I've had one bad TET spell on me at a 4 o'clock in the morning. His name was Nolan Ryan, and I'll never forget this little boy. He turned from 100% sats to 10 in minutes. The blood wasn't going up into his lungs. So, what is my job? First thing. Well, of course, I'm yelling for help, but when you take these infants and put their knees to their chest quick, so underneath their neck and they're on their side, take their knees and push them up. What it does, it changes pressure between the abdomen and the chest, and maybe will pop off what's ever covering that pulmonary artery. And thank God with Nolan Ryan, it did work. And all of a sudden he came back and he was satting 100%. Yes, there's surgery to do. They do repair it. Some are at birth, some are later. It all depends. I've never heard any rhyme or reason which way, what severity of. And the other one I want you to know about is um, transposition of the great arteries. And it has a lot to do with this on the complete left side, patent ductus arteriosus. Well, you took maternity. There's fetal heart, blood flow, right? And with that fetal circulation, it's that duct that connects the pulmonary artery to the aorta, which gives blood flow throughout systemic and pulmonic flow when you're pregnant with a baby. At birth, it usually closes. They say up to 21 days, and usually 2 to 3 days are completely closed. But what if you have a transposition of the great arteries? Well, what are the great arteries that you have that come off of the heart? You have an aorta, and you have a pulmonary artery, right? They're switched. So you're going to have the pulmonary artery going, round and round, and you're going to have, your aorta, and there's no mixing of blood going on. So when that patent ductus arteriosus closes, this child's not getting oxygen. So how do we keep it open? Well, when you are pregnant, you produce a hormone called prostaglandins. And this keeps the patent ductus arteriosus open. When you birth the child, that hormone's not there anymore. So it closes because there's no more prostaglandins there. Now, if you need it open, like for transposition of the great arteries, so you get oxygen, we give synthetic prostaglandins to them. It's a slow, continuous IV infusion. It keeps that duct open until we can do surgery. It prevents emergencies. You can do it a week later. It doesn't matter as long as that duct is open. And it gives cardiac output and it produces oxygen. It is not an antibiotic, has nothing to do with that. All it does, it keeps oxygen and lets the heart beat the way it should. So this is basically, we're talking that PDA, present at birth, right? And many times when they're born, you're going to hear a loud washing machine murmur. You can actually hear it when you listen to them. You also, through their blood pressure, can tell you that it's open. What did I say? The normal blood pressure for a neonate, brand new, is born. It's usually 60/40, right? Well, look at the bottom number. It can be 18 if that duct is still open. So We know that sometimes, and it's a lot of times with your premature infants, that that duct doesn't close the way it should. It just keeps going and you're not doing anything and you don't need it. Well, we can close it. And we do close that with indomethacin. It is actually an IV NSAID, believe it or not. And we know that duct is closing when that blood pressure starts coming back to 60 over 40. Also, we're going to hear that murmur stop. So I think that's pretty cool. And as I said, prostaglandins, they say E2, it's a synthetic thing that maintains the cardiac output and keeps oxygen going. So let's go into some more things. Congestive heart failure. Well, we have adults that have congestive failure, but you do have children too, for whatever reason. Many times it's structural in children, but what it is the heart's not beating the way it should and fluids collecting everywhere. What would be the first thing that I would see in an infant if they were going into congestive heart failure? An increase in weight. The heart's not beating well. Blood's not going to the kidneys. It's not being dumped out. They're not urinating. They're collecting fluids, weight gain. That's why every infant is weighed every day in the hospital. The lungs get all full of fluids and they can't breathe. So, what is our goal? Well, number one, we want to get rid of that fluid, right? Simple furosemide, Lasix. We use this on infants. Another thing, digoxin. Digoxin slows and strengthens the force of contraction. Give that fluid. How do we know that's working? Well, the weight will go down. The kid's not going to be so tachypnic, tachycardic. It's going to be breathing easier and going to be normal kid eating the way it should. Now, when you give digoxin, remember, same things that happen for adults, right? It's an apical pulse, 1 full minute. You're going to check the potassium. You're not going to give it on a low potassium. So you're going to check this with another nurse. This is a high level med that you're giving here. Also, what was the last digoxin level? One of the things I've always taught my parents, if your child is vomiting, you never give another dose of digoxin. It could be the only sign you see that they're in dig toxicity, okay? And once we give all that stuff, they're doing better, they're feeling good, their nutritional status is doing good, we're okay. Now, with congestive failure, before we get it all completely fixed, what do we need to do to help that kid? Well, you don't want to overtire the kid. Never feed more than 30 minutes. Increase the calories per ounce. Even breast milk, you can put fortifiers in it and get increased calories in there, okay? These kids still need their rest. So 30 minutes, you're going to say that's enough. Increase the calories in there, and give them the time that they need. Hypoxemia, very, very common. There's a condition called a hypoplastic left heart, the worst condition that you can have. It's no ventricle on the left side. What does a left ventricle do? It's the engine of the heart, right? It's not working. It's little thick. It doesn't move. And these children, normal saturations at birth are below 85%. I've seen them down to about 60. And we don't give oxygen to these kids because many other reasons, and it's too complicated to tell you, but it's unacceptable. But the body doesn't know that. What does the body do when you don't have enough oxygen? It produces red blood cells, right? So, but you don't have oxygen there. So it continues to produce red blood cells. So these infants become polycythemic. It is not uncommon to have a hemoglobin of 1854 on these kids. This is the thickest, reddest, darkest red blood that you ever see. It's because of the body's defense, and that's polycythemia. Body's trying really hard to get oxygen around, but there's no oxygen to push. You know, these infants, parents, I'm telling you, probably some of the nicest parents I ever met are cardiac parents who have a cardiac child. Again, teaching them how to take care of their kids at home. There are so many groups out for those cardiac things. As like cardiac calf, I already went through. Bacterial endocarditis, again, this is an infection. It's a bacteria. They're going to be needing antibiotics, and this will be the one that you're going to have to give prophylactic before procedures, before cardiac caths, dental works, etc. Now, strep throat is not a big thing, right? Yes, it is. Strep throat can cause two things. It can cause rheumatic fever, or acute glomerulonephritis. That's the GU chapter, week 8. Now, rheumatic fever is a condition where these children have a sore throat and they think it's viral or they think it's strep, and then finally they give antibiotics, and for some reason the strep didn't clear up. All of a sudden the joints get inflamed, the skin is going to get rashing, and then it gets to the point where they go chorea, where they can't control their movements. The one thing that can't be turned around once we determine it's rheumatic fever is heart valve damage. Usually the mitral valve gets damaged in rheumatic fever. So rheumatic fever is due to a strep infection. How do we treat it? Oh, we give antibiotics. And as I said, everything, the chorea, the joints, the rash, the everything, all of that can be turned around and cleared up, except the heart valve damage. That's permanent once it's there. Kids do get high cholesterol. We treat it with diet. They can have Brady and tachydysrhythmias, weird ones. I've seen 2-year-olds with pacemakers before. You know, don't think that just because they're kids, they can't. They do. Pulmonary arterial hypertension is when the lungs are tight, they don't exchange, and because they don't get oxygen the way that they should, these are children that don't have energy. They get really tired at the minimal expenditure of energy, and that's the chest pain and the syncope. Cardiomyopathy is that viral thing that can usually happen, or it could be what? Lupus too, right? Many things can cause it. Usually, cardiomyopathy, after we can't fix it anymore, we can't, quote, tune it up, they go for transplantation. And, you know, rejection is the largest reason for death, but also infection is bad for them. Chest tubes are a big thing. One of the things with children and anything we do for them, you know, chest tubes coming out, and I've worked with adult open hearts and I've worked with children open heart. The adults tell me when those tubes come out, it burns like, but not for a long time, but just like, oh, you know, maybe 30 seconds, but intense 30 seconds. So be honest. Tell the kid it's going to hurt, but I'm going to do everything I can to minimize the pain. Okay? Don't lie to a kid and tell them it ain't going to hurt, because it will. All right? You're going to medicate them before. You're going to take vital signs before. And because you've medicated them, you're going to take vital signs after, okay? And always with everything, it's always on their level. You know, years ago, we didn't check kids 5 years and younger. We never checked their blood pressures. We are now. We're finding there is a lot of hypertension in young kids that require medications. Kawasaki, one of those things, it is a viral thing. It is a what we call a vascularitis. It means the vessels get inflamed But what we are concerned about is the coronary arteries are vessels, and they could have aneurysms. And an aneurysm coronary artery could cause death, right? What do we see in these kids? Well, you see that red cracked lips, strawberry tongue. I'm talking glow in the dark red eyes. You might see some swelling on them too. You might see a rash on them and a fever. And again, this one's a hard one to diagnose. Treatment. This is the time we give aspirin to children, the only time. High dose aspirin. Sometimes they'll even put them on anticoagulants. Why? Well, it's systemic vascularitis. The vessels are inflamed. We want the blood to flow through, right? And then because it's viral, we give intravenous gamma globulins, IVIG. So IVIG, high dose aspirins, and also, or maybe one or the other, anticoagulants. All right. Anaphylaxis, we know one of the things we need to worry about with anaphylaxis, again, is telling the children and parents at the bedside you're giving an antibiotic a first time. That's when I see anaphylaxis happen, to make sure that they know. Again, we know that's going to be your epi. And maintaining airway. When we talk about shock in children, mostly it's due to an infection. Usually they go into systemic shock. And again, supporting the blood pressure, giving those antibiotics. Older kids, toxic shock, usually that's your tampons. So remember that duct that connected the pulmonary artery and it connected it to that aorta, that fetal circulation? If you were to close that, what would happen? Anybody know? Blood is flowing from the lungs into the aorta and from the aorta into the lungs, depending on the beat of the heart. So if we stopped it, what would it do? It's closed. There would be no exchange, right? So it would stop the return of the oxygenated blood. So a lot of stuff there to go over. All right, I have a code, so we'll go over it quickly. If it starts getting late, I'll stop. But this one has a lot of good information in it. Anybody with any questions? It's a
Could you go back
very
to that last question slide? I'm sorry, my brain was not like processing how that was
when
written
you
out.
closed a patent ductus arteriosus, what would happen? Well, we keep it open with prostaglandins to keep blood going to the body through the pulmonary artery to the aorta, right? If you close it, you're not going to have oxygenated blood going back up into the lungs. It's going to continue in the body because now it's closed. It's not going to allow that exchange to occur anymore. There's some questions on the cahoots regarding it too. So we'll go into it some more. What you need to know is how do you keep it open and what do you use? And the answer is prostaglandins. And why do you use prostaglandins? It maintains cardiac output and O2 saturations. Okay, Corey? Okay. All right, we're going to get going because I believe there's 59. I'll go as quick as I can here, guys. And I'll send you a full recording if I don't get through. A majority of upper respiratory infections are caused by what? URIs. What are they caused by? The majority. It's viruses, okay? Strep, no. Upper respiratories, we always say viral pharyngitis, upper respiratory. We do what? Tylenol, Motrin, fluids, rest. That's supportive care. You walk into a 6-year-old's room, child's room, and you find them not breathing and they don't wake up. What are you going to do? Again, a CPR question. So, of course, if they're not breathing, they don't have a pulse, definitely start the chest compressions, call for help, right? Very good. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? Remember, I told you, kids who are sick, what do? They stop eating, they sit in the corner, and you can tell. Sometimes pneumonia, even an urinary tract, fever, vomiting, stop eating. This is like total typical of a child that doesn't feel well. Another multi. What do you look for when assessing respiratory function? Everything. You want to look, you want to see how are they breathing? Are they labored? The depth, the ease, the retraction, infants, nasal flaring. Are they grunting? What's going on? You can tell really quick if a kid's not breathing well. What would you look for after a child has a tonsillectomy? Before these kids wake up in the recovery room, we'll put them on their sides. Because one of the things is they have cauterized, the back of their throats. Bleeding is a big deal with this. And because it's way in the back of the throat, you're going to see them swallowing a lot. They're not necessarily going to be drooling out of their mouth. You see a child post tonsillectomy who's swallowing, 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 I'm telling you, they're going to be bleeding. Never, ever put anything in their mouth. If you tell them to slightly open their mouth, you're going to see blood in the back of their throat. Never a tongue depressor. Multi. Nursing care for a child with status post tonsillectomy include? Years ago, they used to give all of these kids narcotic pain medicines post tonsillectomy. They found kids were being overdosed. Today, all they do is acetaminophen, and it works just fine. Give them their pain medicine, gum for their ears, no spicy stuff that will burn their throats. And older kids will like that ice bag there. It does help. Younger kids don't like it. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? So remember we talked about RSV, we talked about croup, we talked about bronchitis, pneumonia, epiglottitis. Which one? And this is the one that you always dread. It's that bronchitis because you just cough, you can't sleep at night. And the other name, it's tracheobronchitis. That's where it's affected. So it's both of those names. A multi. What signs and symptoms did you see in a child with otitis media? And then I'll ask you, you get a child that has otitis media, you're working in urgent care. What's your priority for that kid? They have an ear infection. It hurts. Medicate them for pain. Priority, okay? These kids might have some oozing coming out, and it could be like serosanguinous, like it could even smell because it's infected. Ear pain is the big thing. And again, loss of appetite. You know, they don't always have fevers. It's the pain that brings them in. The monthly immunization for RSV is, remember, we give this to the premature children, infants with congenital heart defects, respiratory problems, other immunosuppressed type things. We don't want them to get RSV. They can't handle it. It's called Synagis or palvizumab. Be aware of those names. You're going to see those over and over again. All of the following are signs of early respiratory distress in children except early. What do you see? When it gets to the point of bradycardia, you're about to code. Tachycardia, tachypnea, diaphoresis, restless, absolutely. If they're bradycardic, you're about to code. They're on the end. A 4-year-old child's been taking meds for asthma, but they're still wheezing. What information is important to ask? They're taking their meds. Why are they still wheezing? Sometimes they don't know that there's the spacer. Not all physicians give it to these children. I don't know why, but it happens. So I ask them, are you using a spacer? Because you take and you put it on, squirt the 2 doses, they breathe in and out 4 or 5 times, and they get the medicine. And if they're crying, they're taking it in deeper. So it's okay. An 8-month-old with croup exhibits with what signs and symptoms of respiratory distress? Croup, tracheolaryngeal bronchitis. It's the three of them. It's all of it. I remember, croup will go right into epiglottitis if not treated. This is where respiratory distress, those are your keywords, retracting and becoming restless. Respiratory rate of 25, 108. That's actually pretty calm. 95% is fine. And children do abdominal breathe to make it easier. So that's why the other one's the answer. Signs and symptoms of asthma include all except. So croup, epiglottitis, all are upper airway and they can't get air in. Everything up here is swollen. What happens with asthma is the lower airway gets swollen and you can't get the air out. And what they do is when you listen to a child in an asthma attack, you're going to hear nothing go in and you're going to hear a maybe as a noise coming out. It's all about they can't get the air out. They will cough. They coughing because they can't breathe. It's swelling in there. It's irritating. They're short of breath. They're wheezing. But that expiratory phase, that's the problem. So croup is inspiratory, epiglottis is inspiratory. Asthma is the expiratory phase. It gets stuck because it's swollen down there. Signs and symptoms of congenital heart disease include all except. So congenital heart disease, your heart's not working right. That means the kid is working hard, right? They're working so hard that they're not gaining weight. So weight gain appropriate, not a congenital heart defect. Those children need those extra calories in their formula or their breast milk because they're burning it up so much. What should you not do to children diagnosed with croup and epiglottitis or just had a tonsillectomy? Never look into a child's mouth that has upper airway swelling. The croup would be the barking, epiglottitis, they're bent over, they're muffled, there's no spontaneous cough. This, leave it alone. You're going to make more swelling. The epiglottis is what? We know it's a structure in the upper airway, right? An epiglottis. When it's swollen, it's called epiglottitis. And the epiglottis is that leaf-like structure that covers the trachea when you swallow so you don't choke. Okay? Good. A multi. Treatment for infectious mononucleosis. It's an Epstein-Barr virus. So it's a virus, no antibiotics. It's all symptomatic. It's going to be Tylenol, Motrin, rest, and please protect that belly. No contact sports. Multi. When doing an admission of an infant with a low-grade fever and a loose cough, what information is important to know? You're admitting this child to your floor. They have a low-grade fever and a loose cough. What do you need to do a placement? This is the biggest thing where you need to know immunization status. Could this be something different, right? Could this be pertussis? So always make sure that we know immunization status. Of course, we want to know what their fever is and if they've had Tylenol or Motrin and when so we can continue it. What is cystic fibrosis? Again, cystic fibrosis, lungs, small intestines, all the mucus is clogging it up. Very good. What is the greatest risk for an infant having a cardiac catheterization? Remember, this is the first thing I always do when these kids come back. Big catheters are put in the femoral artery and the femoral vein. They've got big pressure dressings on them. Hemorrhage, 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 hemorrhage. They don't have allergic reactions. They're going to have decreased pulses, but it's going to be okay. Cardiac dysrhythmias? No, they usually do not. How is cystic fibrosis identified? So you've had a child, infant, born, has not moved their bowels in 2 days, and they test for cystic fibrosis. What will they find? They're going to find so much salt on their skin, and they do a sweat test, it's called. And as I said, the parents can lick it, and you will taste like really salty. A multi. What is included in the plan of care for a child with cystic fibrosis? Remember, these kids are losing salt like crazy. Remember, it is affecting 2 body systems here. So we're worrying about respiratory, we're looking at nutrition. So aggressive chest CPT, pancreatic enzymes with meals and snacks. And of course, high protein because they can't have fat because it's coming out in the stool. They're losing sodium like crazy. So you never put these kids on low sodium. Give them an extra salt shaker. They're losing it. What is the drug of choice for pharmacologic closure of a PDA? I told you one to keep it open when you need it for cardiac output and for oxygenation, and one that is open and it won't close. And it's called indomethacin. Prostaglandins keep it open. Indomethacin closes it. It blocks that prostaglandin and it closes. That's what it does. What is not a feature of tetralogy of Fallot? Remember, tetralogy is on the right side of the heart. It's that pulmonary artery. It just clogs off. Tissue covers it. Its spasms close. So when you look at this, what is left-sided? Aortic stenosis is not tetralogy. You can't have a VSD, you do. That right ventricle will be stretched when that thing closes. It'll stretch because blood has to go somewhere. And then the pulmonary artery stenosis is absolutely what tetralogy is. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? Which one here? Vomiting is a bad thing. And that's the digoxin. And I always taught my parents, your kid is vomiting, call the doctor. Better be safe than sorry. Why would a child with tetralogy of Fallot not gain weight at the normal rate? This is one of your key nursing diagnoses for this condition. They don't have oxygen and they have no energy to eat. They don't have oxygen. A multi. All are examples of cyanotic heart murmurs except when you look at atresia, you look at stenosis, they're either an absence, atresia, or a narrowing, a stenosis, and blood don't go through. Those are always cyanotic. When you talk about an ASD, blood flows through, right? But aortic stenosis, it's already gone through the lungs. So also, that's good. But that stenosis can also cause backup too. But you're still got proper oxygenation. What is the most common cyanotic congenital heart defect? It's the one I told you that you need to know about. And that's your tetralogy of Fallot. PDA gives oxygen to the body, okay? So tetralogy is when it closes. The most common, I'm telling you, this is the most tested of all of your congenital defects. When you're studying for your NCLEX, studying for your HESI, it'd be one of the things you should look at. Nursing care following a cardiac catheterization. So remember, cardiac cath, they put those catheters in the right femoral artery and vein. You've got the leg there that's moving it around might dislodge, that blood clot there. So always keep that right leg straight because bending it could dislodge it. Okay, you can have the head of the bed up a little bit, but always look for that hematoma. Look for that bleeding out of that insertion site. Multi. Nursing education for the cardiac catheterization include all except so knowing that our biggest concern is bleeding at insertion site, what do you think would follow that? They cannot get out of bed for 24 hours. Okay? And you do not want to bend that extremity because it could make that clot dislodge. Vital signs, pressure dressing? Yes, of course. Which information is most important when rheumatic fever is suspected? What causes rheumatic fever? So rheumatic fever that affects many body systems. The worst thing is that it affects the heart valve is a sore throat. It's a strep throat that wasn't treated properly. That's why when you have children with strep throat, make sure they take all of it, okay? Signs of shock in children include all of the following except shock. What do you see with shock? Shock, you don't have a blood pressure. Your body's what's going on here, usually due to a septic infection in children is the big thing. So hypotension, tachycardia are the two things. You're not getting blood flow, altered mental status. You're not getting blood flow, you're going to have prolonged capillary refill. Very good. Which of the following best describes the pathophysiology of Kawasaki disease? Remember again, this is a viral condition, but it can be extremely dangerous. And it's what we call a vascularitis. And our concern is those coronary arteries. One of the first things that they'll order is to do an echocardiogram to look at those coronary arteries. A clinical manifestation of Kawasaki disease is what? What do you see? So one of the things you'll see is either blistered or peeling skin on the hands, on the palms and the soles of the feet. That's one thing they might see. But the eyes, the strawberry tongue, you might see the rash. These are things that are specific to Kawasaki. Chorea is rheumatic fever. What is the treatment for Kawasaki disease? So remember, it's a systemic vascularitis. Worried about an aneurysm in coronary arteries. Knowing that, we need to keep the blood flowing, and it's a virus, so we need to treat it the best we can. Aspirin and IVIG, and it's usually a month-long treatment. Usually they get it once and they don't get it again. Which of the following is the most common cause of shock in infants and children? You know, infants, they don't have an immune system, right? So one of the big things that occurs with them is they get infections, right? And it does go overwhelming. So if we're starting to see signs of it, we need to treat it immediately. Infection. What are the defects associated with tetralogy of Fallot? Remember, right side. Tetralogy is all right side. So you're going to see the pulmonary artery is small. You're going to have a hole between the ventricles. The aorta sort of gets pushed over because of that. And because of sometimes the blood can't go up into the lungs, that right ventricle gets stressed. So you can see it's all right sided. When you look at the green, it's left ventricle. It's all right side. A child with tetralogy of Fallot may assume which position naturally for having a set spell. As I said, they're all not treated as an infant. Some are later. Remember I said in infants, we do a knee chest, right? Well, you'll see older kids that all of a sudden will they'll squat, and it does the same thing. Changes the pressure from the abdominal cavity to the chest, and it will open up that tet so that they'll be able to oxygenate. Transposition of the great arteries is what? Well, what are the great arteries? So the two big ones, the aorta and the pulmonary artery, are switched. How do we keep this child alive? Keep that patent ductus arteriosus open with prostaglandins. It lends with cardiac output and gives oxygenation for that child. Usually these children, they're not an emergency anymore. You can wait a week to do their surgery, and you get more preparation time. Which of the following is not an intervention indicated for transposition of great arteries? This is a hard one, and I'm just going to go to it. We know that they're going to get prostaglandins. What they do is called an arterial switch. They just switch both of those things. They take it off and turn it around. And sometimes, because they need to get things open, they'll make that patent foraminal valley, that what's in between the two atriums at birth, they'll make that bigger. So it will allow blood flow to go around. Oral does absolutely nothing of anything. These children need more intense for the TGAs. A multi. Why is prostaglandins given to a child with transposition of the great arteries? So prostaglandins helps with oxygenation and maintains cardiac output. Has nothing to do with infections. No infections. It keeps the oxygen and keeps the heart beating because now we can flow. What is the purpose of giving indomethacin to a neonate with a PDA? What does indomethacin do? We know what prostaglandin does. What does indomethacin do? It stops the natural prostaglandins in that duct and it closes. Indomethacin, it's the medical treatment for it. Where is the patent ductus arteriosus? What does it connect? Well, we know it has to do with oxygenation. We know it has to do with cardiac output. So what does it connect? It connects the aorta to the pulmonary artery, and then it allows blood to go systemically from the lungs. This heart defects allows blood to pass from the left ventricle to the right ventricle. What is it called? Well, is the right ventricle and the left ventricle connected to each other? No, that septum is interrupted, so it's called a VSD or a ventricular septal defect. Good. A multi. What is a sign of ditch toxicity in infants? So we know it's the vomiting, and yes, decreased heart rate. In adults, they might see yellow spots, okay? Digoxin toxicity has nothing to do with infections. What is congestive heart failure? It's just when the heart's weak and it can't pump the way it should, so blood sits in the lungs and it fills up. Left-sided congestive heart failure causes what? So if that left ventricle isn't working well, where does the blood go? It goes backwards. Think of a garden hose. If it's kinked, where does it go? It goes back. And it fills up the lungs because it's not pumping the blood out the way it should. And because it fills up the lungs, coughing, shortness of breath, tachypnea, tachycardia, and of course, bronchi, rales. After a heart transplant, what is the leading reason children die? And it is rejection. Rejection is number one. A multi. Signs and symptoms of rheumatic fever include, remember, rheumatic fever is due to a strep infection that was not completely treated. And it attacks the body. And it creates a little bit of everything. And remember, the one thing that cannot be turned around is the heart valve damage that it causes, but all of this other stuff can be reversed. A multi. A child's about to have a chest tube removed. What should you do? I might tell you it burns. I've had the opportunity to do both adults and children. So it does help me taking care of kids and it helps me taking care of adults. I like both areas. But let them know it's going to hurt, but you'll do everything that they can. And also medicate them for pain. They don't know to ask. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What is your priority? If they don't expectorate secretions, they're going to have lung problems. So how can you make that kid cough? You're going to medicate that kid for pain. Then you're going to get them up out of bed, use incentive spirometry, reposition them, and they're going to cough and everything will be fine. You're not going to cough if your tummy hurt, if you don't have pain medicine. So use the pain medicine and distraction too, right? An infant as a 3-month-old has a fever of 103.6. What do you medicate the infant with? 3 months old for fever. What do you give? Only acetaminophen. You do not add ibuprofen till they're 6 months old. Something to do with bleeding coagulopathies. They can't tolerate it till they're 6 months old. A newborn infant is assessed. The nurse finds very weak lower extremity pulses. What should she assess next? What does that sound like? Well, no pulses, and it's a newborn, probably coarctation. How can you justify that? If you have lower extremity blood pressures and higher upper, and that's probably guaranteeing you that's exactly what it is. So 4 extremity blood pressures is how that you would assess. Yes, that's your probability. It is coarctation. A critical ill child is on complete bed rest. What can a nurse do to prevent complications? We think only adults are in bed forever and get sick. Well, there are children that are there a long time, and you think all of those complications only an adult can get. You're wrong. Children can do too. So you've got to do preventative stuff. You are going to use that incentive spirometry, keep their lungs going. You're going to use pillows, blankets, toys, whatever, turn them, position them, and keep them dry. Also, you're going to use a sheet to pull them up. You're not going to do that shear, just pulling them up. And that could have some shear complications and pull skin off. And yes, children can get that. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? I mean, how many infants come out and we have what we call TTN, which is transient tachypnea of the newborn? It's just they need a little time, a little bit of something to help them, and they come through it. It's not that they have any, serious issues, but they need a little oxygen. Give them an oxy hood. It's clear. They can look around. They can suck their fingers, a pacifier. It's the best. Everything else is nasal cannula. We tape them on. They'll rip them off. Blow by. It's not accurate. And an endotracheal tube. Have you ever been intubated? I have, and it is not tolerated very well. You can feel like you're choking. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? So, one of the things that we do, deep breathing, coughing, all of that good stuff, give them an aerosol with like albuterol to open them up, give them chest CPT, and make sure you do this before they eat. You would never do that after a meal is given because they'll vomit. And ambulate, not PRN. They need to be out of bed, QID, TID, something. And exercise is always good. As I said, swimming is great. A multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? Remember, they're not digesting their foods well. They need this to help get them the foods and make the body have it available to them. It's with every meal and snacks. So take it right before the meals, not an hour before, right before it. You could put it on the food. Also, if they use the powder type, make sure they rinse their mouth. It's just like using those Symbicort type things that you would have to because it affects the enamel on their teeth. You must rinse it out. And remember, kids grow. And it's one of the things we forget, even with seizures and whatnot. Make sure that we increase those doses as they get bigger. What is a cardiac defect where there's no valve between the right atrium and the right ventricle? What valve is there between the right atrium and the right ventricle? It's your tricuspid valve, and it's called tricuspid atresia. Atresia means nothing, nothing's there. Stenosis is a slight narrowing. That means it's not open the whole way. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feedings, what should you assess? What could be going on? This is telling you the lungs are filling up, going in congestive failure. Yes, check breath sounds. Very good. A lot of stuff tonight. Brian, good job, Brian. Number 3. Number 2, Corey. Good job, Corey. Number 1. Do-do-do-do-do-do-do. Oh, it's a K. Okay, K. Sarah and KF. So this is your week 5. A lot of information. I know it's a lot. I think I've covered everything that you needed. Anybody who needs to review exam 1, let me know. Send me a message. Remember, next week is going to be your exam 2 reviews. I'm going to be doing mine Wednesday night before class, about 4. Would it be better if it's earlier in the day for y'all, like 2? Yes, no, maybe so. All right, anybody who has a preference, let me know. But again, you're going to get the recording. Have a good night, guys. Thank you so much.
Thank you.
No, my pleasure.